Thank you, Atish. It's my pleasure to introduce our speaker today. Dr. Chirala is a cardiologist and a clinical assistant professor of medicine at Stanford, where she just came from her Thursday clinic. And it looks great after sort of battling traffic all the way to the South Bay. She also has great interest in developing mechanisms to maintain physicians connected to their patients and do this sort of chronic management of patients using artificial intelligence and wearables and technology. Today, she will be actually talking about sleep. One of the things that we say at the South Asian Heart Center is that you need to live well to live well. And in order to be able to live well, you actually also have to sleep. We spend 8 of the 24, that is 1/3 of the time, is supposed to be spent sleeping. The South Asian Heart Center at the beginning, 20 years ago, identified sleep as one of the core factors that went into our MEDS program, which is meditation, exercise, diet, and sleep, on the basis of the Alameda 7, which was this very long 25-year-old study following 7,000 individuals from the Alameda County, identifying factors associated with longevity. We also are, as an organization that practice science-based Vedic approach to health. In the Vedas, it's stated that yoga is for he who does not sleep or sleeps too much. So with our a theme of rest and recreation, we have a fantastic speaker who will talk to us about high quality of sleep and that which prevents good quality sleep, such as sleep apnea. So please welcome Dr. Chirala.
Thank you, Molina, and thank you, Ashish. Thank you for giving me this opportunity, and congratulations on your 20 years of excellence and for more to come. Let me start by... Okay. Am I visible now?
Yes, you are.
Okay.
And your presentation is there as well.
Okay, very good. So, again, thank you so much for giving me this opportunity. This is a serious topic that is very close to cardiologists, and it really pulls down their patients a lot. And I thought I will bring this to light. And here I am doing that. I want to start with saying that, people, please don't think it's about snoring, what I'm going to talk about. It's more about the sleep that is very important for your heart health, for your brain health, and for your overall life. So basically, what I wanted to start with is some of the problems that's been bothering the South Asian community. Heart disease, as we all know, is number one cause of death and morbidity and mortality in the South Asians worldwide. And we carry a huge burden of that. That is about 60%. And it's only there to increase in the next 2 decades or more. And the key of us, the South Asians, getting it at a much younger age, 10 years earlier. The average age of having a heart attack in the Indian population is 53 compared to 63 in the US population. And what I want to bring about is this hidden condition that could be the trigger that's causing all of this, that's making all of this worse and worse. And that's what I want to bring into light today. So today you will learn about this disease called sleep apnea, how to recognize it, why as South Asians we have this increased risk, what it does to your heart, to your brain, and what you can do to protect yourself. So I'm calling it the silent epidemic. It's an epidemic. Almost 1 billion people worldwide have sleep apnea, but unfortunately, only 10% are recognized, are diagnosed. 90% are underdiagnosed. And that is a big problem, not only a problem, that's the crux of the whole issues, because as you see this iceberg, the tip only 10% is visible, but the danger behind underneath is that 90%, that is the damage, the heart damage that's being done night after night. And that is the 90% that's lurking underneath. So out of the 1 billion people, over 100 million of Indians are affected, 54 million of the Americans. And again, only 5 to 20% of are diagnosed. So it's a huge number, a huge problem, a huge burden. The global prevalence, as you can see, the prevalence is actually highest in the United States, 30 to 35%, but the absolute numbers are the highest in China because of the population, followed by India and of course US. So it's there across every continent. This pandemic is hiding in the bedrooms across every continent. And our country carries one of the highest burdens in absolute numbers. And this is what I will explain more. So basically, what is sleep apnea? Sleep apnea is your breathing stops repeatedly when you sleep. This is more than just sleep hygiene, how much you sleep, your total sleep time. It's a lot more. It's about your breath. That's why I call it the breathless heart. It's when your breathing stops when you sleep. What happens is, imagine your throat. Let me see, laser pointer. Your throat as a soft rubber tube. When you're awake, the muscles around the throat hold it open. When you fall asleep, these muscles relax and the tube collapses. When it collapses, oxygen doesn't go through. Oxygen level falls, the brain panics, wakes you up, and then you wake up with a big snore or a snort, and that pops the tube open again, and you take a deep breath, and then you fall back to sleep again. You have no memory of this, but this happens over and over again, 30, 40, 50, 60 times every hour that you sleep. So 2 main types of sleep apnea have been recognized. The obstructive, which is most common, 90%, and that's when I was talking about the muscles around your throat that relax and block the airway. Second one is the central sleep apnea. Thankfully, it's not much. It's only 10%, where your brain doesn't send proper signals to breathe. And this is very common in heart failure patients, very dangerous. During these episodes, your breathing stops for more than 10 seconds. And when you start looking at a lot of sleep studies, sometimes it's amazing how many seconds a person can hold his breath as per the sleep studies. It's amazing. And they're not even swimmers. They're just normal people. So you hold your breath, your oxygen, drops, and then it goes over and over again. Going to the anatomy. So I want you to actually do this exercise. It is open your mouth. Well, your doctor does that, tells you to open your mouth and say, ah. When you do that, you should be able to see your soft palate, your uvula, the one that hangs down, the hard palate above that, and the pillars, the tonsils. You should be able to see the back of your throat. That's normal, and that's class 1. If you don't, if you see a little bit, it's class 2. If you're seeing just the tip of it, or the base of it actually, or if you don't see anything, puts you at major risk for sleep apnea. Very simple for each of you to look and see where you are. So why this matters to South Asians, I will go over that again. But remember, we have smaller airways, craniofacial differences more than other populations, a chin that's a little backwards, more fat around your neck, and lower body weights, which can still be dangerous. So this Mallampati score, class 3 and class 4, danger. And just a sideline, Dr. Mallampati was an anesthesiologist at Harvard. But before that, he had done his training in his medical school in my alma mater in Andhra Medical College in Vizag. So I'm very proud about that and use it liberally in my patients too. So some of the differences between South Asians and the Western populations. This key is the BMI, the body mass index. We are thinner, so we get obstructive sleep apnea as a thinner BMI. More than 25 versus typically Western populations more than 30. Similar to our heart disease onset. Remember, we get it 10 years earlier. Higher diabetes risk, 4 times more. All of these, of course, it's underdiagnosed in both in India and everywhere else too. But all of these other risks, make the sleep apnea even more dangerous. So at a lower BMI, we have a higher risk of this sleep apnea. It's not one single factor that gives us this high risk. If you go through, it's the body, the higher, we have higher, even though we are thinner, the BMI is lesser, there's more body fat percentage, more visceral fat around your neck, around your organs, and that's an increased risk for heart disease. Craniofacial features, smaller airways, different jaw structures, and metabolic. Of course, we have more insulin-resistant diabetes, and a lot of genetics. Sleep apnea is hereditary. So if your parents have it, there's a higher chance you have it. And Indians as a whole, I know I mentioned this last time in my prior huddle, we have a 25% increase in elevated lipoprotein A. 25% of the population have elevated lipoprotein A, which together with sleep apnea is not a good thing. So this is the perfect storm. The genetic, metabolic, all these lifestyle, factors causing increased sleep apnea risk for our Indians. They create that perfect storm. What's the actual prevalence? Overall prevalence is less than US or other. It's only 11%, but since our population is so much, this data is kind of old, 2012, and there's some more newer data that says it's a little bit more. Men definitely have it 2 to 3 times more than women all across all populations. And moderate to severe is about 5%, that's 47 million. Urban areas more, more sedentary lifestyle, metro cities. Of course, rising obesities, it's directly linked to obesity. Again, the key, only 10% are diagnosed in India. So only 10 million know it. The other 94 are undiagnosed. And more than that, to diagnose it, we need sleep labs. The amount of sleep labs in India is 0.5 per million. In US, it's better, it's 5 per million. But still, US, it's still 80% underdiagnosed. So we got a lot of work to do on this. A few words on the South Asians living in America, all of us, some of us, some challenges, changes in our culture, dietary, sedentary jobs, and more diabetes. I'll go through this. The guidelines that have been written for diagnosing sleep apnea really don't apply to us. Really don't apply to us. We get it at a much lower thresholds, almost all around. So we come to America. we inherit a lifestyle, that is different. We already have some risk genetically, but here we come in, we trade the walking markets for driving, home cooking for takeouts, a lot of socializing for desk work, and a lot of screen time. Each of these nudges us closer and closer towards that sleep apnea. But we still have that genetic predisposition. That doesn't go away. A few words on this obesity paradox. So the standard BMI categories do not apply to South Asians. Quite unfortunate. So overweight in the rest of the populations is obese for us. That's it, 25. 25 BMI is obese. And that's our risk for getting sleep apnea. Most of us are 25, aren't we? I mean, it's scary, but that's what it is. And so with that lower BMI, we have a lot more prevalence of this obstructive sleep apnea with the lower BMI. I want to drill that in. So if your doctor says, oh, your BMI is 25, you're great, you have to actually correct and say, no, I'm a South Asian. That's not. I'm considered obese. I'm at increased risk. So share this with your family doctor. So we'll talk a little bit about the warning signs. This is common knowledge, but I still want to review because, and of course, your partner is the first one to struggle and suffer and let you know about all of this. Talk to them. Always talk to your partner and say, did I snore? Did I stop breathing? It's not snore. Snore, they'll tell you. But more importantly, did you see that I stopped breathing? Was I gasping? And then they'll make an effort to look at you. So it's not only the snoring, it's the gasping, it's the pauses in breathing. That is the most sensitive signs or features that's there. When somebody says you're not breathing, and I have to tell you, wake up, take a breath. That's very, very relevant, and that person has sleep apnea. Frequent bathroom trips. As we get older, that gets more and more and more. Actually, that's related to these arousals. When you take a breath against this blocked airway, there are these hormones that are released, the ANP hormone, it's called an atrial natriuretic peptide, that causes your kidneys to produce more urine. That's one of the cause. It's not only your prostate. Sleep apnea is very much cause of that. So if you get up several times and you blame something else, please don't. Look at your sleep. Waking up with the dry mouth, insomnia, night sweats, teeth grinding. So these are all the nighttime symptoms. Let's go towards the daytime symptoms. Tired. People keep saying I'm tired is normal. It is not normal. Tired is common, very common, but it is not normal. And it matters. It matters a lot when you start saying feeling tired during the day, not enough sleep, morning headaches, the brain fog. You can't concentrate. You're walking around in this brain fog. Remember in COVID times, we all had that brain fog after you get COVID or the post-COVID brain fog. That's what sleep apnea gives you. And of course, you're falling asleep. A lot of anxiety, depression, signs and very classic. And of course, ED, decreased libido. So the key factor I want to also present is many people don't have any of these symptoms, or at least they come to the doctor and say, I don't have any of these. These are the silent presenters, even more dangerous, because they come in straight with the heart disease. No symptoms, no signs, and they present with heart disease, just very high blood pressure or AFib or something. So after the symptoms, just a little assessment of your risk. Are you at risk? What are these risk factors? Just go yourself, the physical factors, medical conditions, physical. We said body weight, obesity. Remember 25, not 30, not 35. 35 is morbid. Neck size, very important. 17 for men, 16. Now I think it's overall 16. Age over 40, males more than females. Menopause, let's not forget the postmenopausal, as it's a lot more in them and they should be screened more. It's hereditary, so family history, because the jaw structure runs in families, the airway size runs in families, the obesity propensity runs in families. So all of these, the physical factors, medical conditions, I'll go through each in detail. High blood pressure, diabetes, heart, stroke, CKD. If you have any of these, you are at risk. You are at risk. And like I said, I will explain these after I review how the damage occurs. What is this pathophysiology? What is the sleep apnea doing? It's doing a lot. Basically, what it's doing is it's punching you in the chest 40, 50 times at night and letting you fall back to sleep. Every punch it gives, it raises your blood pressure, it stresses your heart, inflames your arteries. Now you multiply that by 365 nights a year for 10 to 20 years. That is what it does. This is scientifically accurate. So first thing, what it does is the hypoxia. Hypoxia is low oxygen. Low oxygen levels. You stop breathing, your throat, the tube collapses, oxygen levels fall. That causes oxidative stress, inflammation, huge marker for inflammation. The intrathoracic pressure swings. That means when you're breathing against this closed airway, there is a lot of negative pressure in your lungs and heart. And that increases what we call your resistance, your afterload and preload. So the heart has to work much harder. The heart is training very hard to work. So is your lungs, because of the pressure swings. And the more you hold your breath, the higher negative pressure, minus 50, minus 60. The sympathetic surges. So what happens is there's swings of these hormones, cortisol levels, adrenaline. It spikes up. And when you have these surges, it increases your heart rates, increases your blood pressure. And this is the fight or flight response, the catecholamines. Not good when you're supposed to be sleeping and getting the best rest for your heart. A lot of metabolic dysregulation. It causes the insulin resistance, thereby giving you the diabetes, fat storage, hormonal imbalance. This is what I'm calling the cardiovascular cascade. Airway collapse, your oxygen drops, many arousals, pressure swings, sympathetic nervous system, SNS, that is activated. You get all these catecholamines, adrenaline surges, inflammation, oxidative stress, endothelial dysfunction, all of these. So that inflammation, what I'm saying, inflammation, your CRP levels are high, all these levels are high, it damages arteries. Atherosclerosis is known to be an inflammatory. It starts with inflammation. So the oxidative stress. So, people have high cholesterol. It's just, it just does its job. It shouldn't really go in and clog up arteries, right? Everybody has cholesterol. We have to have some cholesterol. But when the oxygen level drops, it causes inflammation on the lining of your arteries. That damages a small area, and that oxidative stress and inflammation causes the first, plaque or drop of cholesterol to go in and get stuck there, and then it starts more and more atherosclerosis. And of course, the sympathetic nervous system, your blood pressure, heart rates, all are elevated. So this is a chronic cardiovascular stressor. And I'm going to go through each of these so that you understand more deeply about these, what the cardiologist sees day in and day out. sleep apnea and how it affects the blood pressure. So the association, I want you to see the connections between all of the next few diseases and sleep apnea. So sleep apnea is presented in most of hypertensive patients. There is something called resistant hypertension. That means when you're on more than 3 blood pressure medications, that's resistant hypertension. 80% of resistant hypertension patients have sleep apnea. That's the cause. All hypertension patients, at least 40 to 50% have sleep apnea. Is the most common cause of the secondary hypertension. Primary hypertension, called essential hypertension, you inherit that. But the secondary hypertension, this is the most common cause. So what happens at nighttime? When you sleep, normally your blood pressure has to dip. The dippers, very important. That is the time your heart gets to relax. In night sleep, your blood pressure has to nicely relax. Your heart rate goes down and then it rejuvenates your heart and your brain. But no, the dipping is gone. You get these spikes of blood pressure, heart rate, blood pressure becomes elevated. And we have studies to show exactly at the drop when you stop breathing, that's when you see these spikes. And then initially it's only at nighttime, and then it goes towards the day, and then you become hypertensive. So there is treatment impact, and I'll go through the treatment impact again, but the treatment impact does help these high blood pressures. So one of the most common epidemics that hits the cardiology offices, atrial fibrillation. This is the rhythm connection for sleep apnea. It is, I keep telling my patients, you have AFibs, you have atrial, you have sleep apnea because it's married to each other. 80% or more of atrial fibrillation patients have sleep apnea, and it's present, sleep apnea is there in more than 80% of atrial fibrillation patients. It increases your risk several times. And again, let's talk about how it does it. Acutely, when you stop breathing, the oxygen drops. That low oxygen triggers the high heart rates and the arrhythmias. It also triggers your vagus nerve. It stimulates your vagus nerves and slows the heart rate. Very common. We see a lot of bradycardia. They come in with low heart rates. And then when you suddenly wake up with that snort or that big, that noise, that causes your heart rate to surge again. That's the acute. Chronically over time, night after night, minute after minute, then your left atrium starts enlarging. That's the top chamber. It gets scarred, big, remodels, and that's where the atrial fibrillation starts occurring. That chamber, the left atrium, is where all these erratic waves start coming out and cause the atrial fibrillation. Treatment is useful. I'll go over this again. CPAP will help this treatment. So next big condition, heart failure. I'm so sorry. Everything is big in sleep apnea. Everything is big because cardiac, that's the thing. It hits all aspects of cardiac issues. And I'll go through that again in other slides, which is this heart failure. It's a very dangerous bidirectional relationship. It is presented in 40 to 60% of heart failure. Remember that central sleep apnea, that's more in the heart failure patients. Heart failure patients have centrals. It's even more dangerous, even more difficult to treat. The sleep apnea makes your heart failure even worse. It's a vicious cycle. Each makes the other one worse. How does it happen? So remember, when you have that negative intrathoracic pressure, it increases the afterload, the resistance that your heart has to pump against. That makes your heart work harder. At night, when you're supposed to be sleeping and having sweet dreams, well, you keep waking up. It activates the sympathetic nervous system. Heart rates, everything gets elevated. That stresses the heart. The hypoxia causes the oxygen to drop, and your heart needs the oxygen. All these fluid shifts at night, they worsen, they cause the congestion, the fluids, So all of this is this is the reason why it happens, why heart failure is correlated so much. These are some of the reasons. And the next one, I got a lot of slides, so I just want to go through everything. Sleep apnea and stroke, the stroke connection. It increases stroke risk by 2 to 4 times. Basically, when somebody has had a stroke and you have to really test them for sleep apnea. There are many reasons why stroke patients get the stroke, but most of it is related to sleep apnea. And how does it do that? Remember, sleep apnea causes the inflammation, and it promotes atherosclerosis. So when you have plaque buildup in your main arteries in the brain, and then those plaque breaks loose, you can get a stroke. It increases the clotting tendency. It makes your blood more thicker, the low oxygen. The blood pressure surges. Sleep apnea blood pressure is not normal, essential hypertension, blood pressure 150, 160. They come in with high 200, 240. They walk around with 200, 240. And this puts them at high risk for the strokes. And remember that atrial fibrillation triggers, it causes clots. All these clots hide in a small little pouch called the left atrial appendage, and that breaks loose, and it's a huge cause for strokes. And the culprit, sleep apnea. So, and of course, the blood flow is reduced. So this is the acute why strokes happen and why sleep apnea is responsible. And of course, it impairs your rehab, recurrent strokes. But again, we have some improvement with treatment. This, I feel, is the smoking gun. This is just not fair. It's the time reversal. So generally, if normal people shouldn't have cardiac arrest, but if normal people are going to have a cardiac arrest, the timing is the early mornings, 6 a.m. to 12 p.m. That's the time that people get cardiac arrest. But it is very different for sleep apnea. It's 12 a.m. to 6 a.m., middle of the night. When your blood pressure is surging, the heart rates are surging, the arrhythmias happen 2 o'clock, 3 o'clock, 4 o'clock. You're just not even prepared. Your partner is not prepared. You just get lethal arrhythmias and you have cardiac arrest. So that, if you survive that cardiac arrest, have to be tested for sleep apnea. Seen it in multiple patients. Why? Why does it happen? That severe oxygen desat, when the oxygen levels drop 70%. Remember, normal 95, 100% drops to 70, 60s. I've seen as low as 50. Dangerous. It triggers that arrhythmias because there's no oxygen in your cells in the heart. That high sympathetic surge, catecholamines, adrenaline surge causes dangerous rhythms. Remember the vagal nerves, it's stimulated, the heart rate slows down. That can make your heart stop and you have a cardiac arrest, and it prolongs the QT. So what are the risk factors for who are the people who are likely to have this sudden cardiac death? Who have very severe OSA, when the oxygen level drops a lot, or if they have underlying severe heart disease or untreated sleep apnea. Brain. I just maybe 1 or 2 slides on this because it really is so meaningful. The cognitive and neurological effects of not having oxygen to your brain is huge. Directly all cause dementia, Alzheimer's, Parkinson's, 34%, 28, 54. Same thing. You drop your oxygen, you damage the neurons. There's also something called the glymphatic system. There's the cleaning that goes on in the brain when you sleep. It's like the lymphatic system. It's called the glymphatic system. It cleans up all these toxic proteins. Yeah, have you heard about the amyloid beta amyloid and the tau proteins that we see in those PET scans for Alzheimer's patients? It lights up, and you get, because of all these amyloid and the beta proteins. These proteins have to be cleaned out by the glymphatic system. When you are sleeping, When your sleep is fragmented and you keep getting aroused, the cleaning stops. So these dangerous proteins all accumulate in your brain. And then you get your dementia and Alzheimer's. This has been proven. And, this inflammation. So all these spots and all that you say, you have to take it seriously. I almost all test everybody for sleep apnea. You get the memory problems, brain, difficulty concentrating, yeah, all of this. Few words on diabetes, since South Asians have so much of diabetes, 4 times more. It's a lot of people, lot of diabetics have sleep apnea. It increases independent of obesity. How? That low oxygen promotes insulin resistance. It causes that insulin resistance in the pancreatic cells get damaged because of the inflammation, and you get type 2 diabetes, hormonal imbalances, and same the glucose dysregulation. And it's very important for South Asians because we are at higher risk. So you add this diabetes, and then you add sleep apnea on top of that. So it's your double, triple risk. Then it's beyond the heart. Yeah, we're seeing a lot of this. The latest thing is now this fatty liver. A lot of people have elevated liver function tests. It's called NASH, MASH, NAFLD. So many new terms have coming out, but it is huge. Like 30% of the population have it. It's huge. And this is also linked to your low oxygens at night that drives the fatty liver. Now, this hypoxia, again, I don't want to go too much into this big black hole called cancer, but there's more and more studies saying that the low oxygen promotes tumor to double and triple the oxidative stress. All of these increase your incidence and of getting cancer and increase your chance of dying from cancer. It may not cause the cancer, we don't know so much, but there is a dangerous relationship between cancer and sleep apnea. Kidneys, kidney disease, non-alcoholic liver disease, it's a lot of the ED, it causes your testosterone levels to drop, decreased libido, gestational diabetes, anxiety, depression, quite associated with this. And most importantly, we should not forget the increased risk of motor vehicle accidents due to falling asleep while driving. That's a lot of lost lives and, and revenue. So this is it. This is what the cardiologist does. All day we see heart failure, strokes, heart attacks, coronary artery disease, heart attacks. They go to stents, bypass, arrhythmias, atrial fibrillation, ventricular, pulmonary hypertension, resistant hypertension, depression, sudden cardiac death. So what am I saying? This is the crux. That's the center of it. No matter how I look at it, when I test all my patients who have all of this, almost all seem to have sleep apnea. I just can't ignore it anymore. And that's why I feel I need to bring about this awareness. It's like a nightly vascular poison, silent, repetitive, cumulative. I also did some testing in my own, because now we have electronic medical records. This is in the general population. The prevalence of sleep apnea in drug-resistant hypertension is 83%, obesity, heart failure, pacemakers. This is my patients in the last 10 years, 1,700 of them. And see, all 50%, 40%. And one key thing that I'm seeing, which again, I'm hoping to see if I can get some studies going on this, is your aorta starts dilating very early on. Very early on, your aorta starts getting dilated, your heart rate comes low with the blood pressure. When I see 20, 30-year-olds with high blood pressures and low heart rate, first I think about sleep apnea. And when you do the echoes, most of them starts dilate, and then later on they get into the aneurysm. So just to show this is what I'm seeing in my office. So we'll talk about diagnosis, who should be screened. So obviously all these dangerous situations that I just spoke about, heart failure, atrial fibrillation, resistant hypertension, coronary disease, everybody needs to be screened. All of these should have a sleep study. Diabetes, remember BMI, So commercial drivers, we'll talk about that. How is it diagnosed? What's the diagnostic pathway? I broke it up into clinical assessment, sleep studies, and the interpretation. It's become a lot easier, So the clinical assessment symptoms, we went about the snoring, daytime, nighttime, stopping breathing, classic, that's the most sensitive. Physical exam, measure your neck. Look at your airway. Is it crowded? The dentists will help you so much. They diagnose so much of sleep apnea. You open your mouth, said, everything is so crowded, small airway. I can't see the back of your throat. And the screening questionnaires, which I'm going to go to, like the sleep lab, the sleep studies and how we diagnose them. So the stop bang screening tool, this is a take home for all of you. Very simple screening that as a cardiologist, I do it in all my patients, and so should everybody else. And then we'll be very quick to get that 90% down, right? Undiagnosis. So do you snore? Do you feel tired? Have you been observed to stop breathing? Most sensitive. Do you have high blood pressure? What's your BMI? Your age? Neck circumference? 16, 17? Males. So if you have, anything more than 3, it's kind of positive, intermediate risk, and you go on to the next level of testing. 1 or 2, you're low risk. Okay. So the 2 kinds of testing is the in-lab sleep study and the home sleep study. In-lab is called PSG, polysomnography, is the gold standard. Measures a lot. Look at this. Look at all, you got to put a lot of this stuff all over your brain waves, your eye movements, your muscle, your heart, your respirations, the airflow, everything, oxygen. But it's the gold standard. It is cumbersome. There's a long wait to get these. Very few centers, 0.5 per million in India and 5 per million here. At least in Stanford, there's a 1-year wait to get these. But it is the gold standard. When you suspect certain patients cannot get home testing. And it is, if you have like central sleep apnea, if you suspect, only this will diagnose central sleep apnea. If you have heart failure, you have to go straight for a PSG. If you have severe lung disease, severe PSG. And if you had a stroke, PSG. So some things, and if your home sleep testing is negative, then you have to get a PSG. So it gives you lots of information. It's the gold standard. It's hard, and it's not a screening test. So we go to the next level. These have become amazingly accurate and a lifesaver for the medical community. Getting better by the day thanks to AI. Very convenient, and they have different channels and different devices, and it's like a home blood pressure monitor. It's very powerful, it's practical, and it's available to a lot of people. Can just do this. Of course, it's just the beginning. Remember, this doesn't solve the whole problem. It's just it screens you and say, yes, you may have it. But then we got a lot more to do after that. So, it's affordable, convenient, faster, but it doesn't get the central sleep apnea, and it can underestimate the severity, and it's not suitable for all, but it's very convenient. It's some of these, the newer ones, is equal to 80, is as it's 80% as good as the PSG. 80 to 90, some of them say 92, but I don't know. 80 to 90% as accurate as PSG, the new with the AI, evaluations and stuff. So how do you, what are the sleep studies measuring? This is the key AHI index. That's what we all go by. So we need this AHI index to actually diagnose sleep apnea. Normal is less than 5. You're okay. 5 to 15, it's mild. 15 to 30, moderate. And more than 30 is severe. How much your oxygen drops. I think I need to get a little faster. So these are the home devices. Very simple, just a watch or a ring or a patch. That's it. Depends on what all they measure. You get level 3, level 4 devices, very smart watches. And we have some emerging technologies, AI and wearables, but this is only for screening. It's not for diagnosis. They are going to basically give an EKG that's going to predict your risk of getting sleep apnea. And the Apple Watch that's been, last year's come out with, we can diagnose. You can't diagnose. You screen. You detect something there. You don't detect the AHI index, but that is enough to put you in front of the doctor. That's all. And these microphones will get your snoring. And so going to treatment, you have to treat OSA as a metabolic driver, whole cardio-metabolic. Remember all the things it causes. The core therapies, CPAP, of course, you have the weight loss, positional oral. And all of this you base on the severity. Who gets what is based on the severity of your sleep apnea, your phenotype, your jaw structure, and how much you're able to do it. And it, of course, it reduces the drop in oxygens and your arousals, and it treats some of these symptoms. Gold standard, like the PSG is the gold standard. This is the gold standard. Continuous positive airway pressure. This is it. This is all that helps us in treating this dangerous, really dangerous disease that's there. It delivers air. There's no oxygen. It just takes the air from outside and it pushes it. When you stop breathing, it just acts as a splint and it pushes the air inside. So it keeps that airway open. So your oxygen levels are always over 90. And it normalizes AHI 90% of the individuals while wearing it. The 3 types, CPAP, which is continuous, APAP, that's auto, and BiPAP, that's different levels. That's more for heart failure. And it does a tremendous job. It decreases your AHI. Remember, anything more than 30 is severe. It reduces that a lot by 30 events. It improves your daytime sleepiness. It improves your blood pressure. Of course, everybody feels, I cannot wear this. It's too much. All this adherence. It's not bad. For you to get benefit, Medicare to pay for this, you need to use it for more than 4 hours. That's the key. If you use it for less, it won't pay for it. And it monitors the compliance reports. And it's more than 70% of the nights. And 70% of the people, actually 75% do it. They do very well. Most of my patients do quite well. And at 4 years, 65 to 80% continue to use this. You have problems. You just have to deal with it. Dry mouth, you get the humidifier, mask, change the mask. See, you get the nasal mask, the nasal pillows, the full face, whatever. Claustrophobia, you try a different mask. You try a different CPAP. You just have to work with it. Because the benefits are tremendous. Remember, it drops your blood pressure. For resistant hypertension, it drops your blood pressure. Using CPAP, heart failure, it improves your heart function. Atrial fibrillation, if you get cardioverted or you have ablation, it prevents the recurrence by 42%. Stroke, it decreases. It decreases all-cause mortality in severe obstructive sleep apnea. Only if you use it for more than 4 hours. The next level is the oral appliance, what we call the MADs, mandibular advancement devices. These is what our dear dentist friends make, and they very, very useful because more tolerable. They also reduce AHI, 13.6%, but it's mainly used. So what it does is they put these devices, they fit it towards your jaw, and it gently pulls your jaw forward, and it creates a little extra airway space, and it prevents that airway from collapsing. Not used for severe sleep apnea, only for mild to moderate, or people who cannot tolerate the CPAP. Surgical, I think we'll forget it. This is, the uvula, we rarely do these surgeries. There's this huge MMA surgery where they do a lot of reconstruction to your whole jaw. It's pretty gruesome. Inspire, that's the new one that's come out. I'll talk about that. Some nasal surgery. Of course, weight loss surgery will help. And Inspire, this is the new one that's been approved by FDA, and where if people cannot tolerate, remember, first line CPAP. If not, then you can get this Inspire therapy where they implant under your skin this and they stimulate your hypoglossal nerve. It stimulates the nerve, which it activates your tongue and keeps your tongue forward instead of falling backwards and collapsing and causing the CPAP. It does a good job. And, but you need to do some testing called DICE before. But it is not first level. It's secondary. Lifestyle modifications, extremely important. Now with the new GLP-1s, tirzepatide, it's been approved, Zepbound, it is going to be a game changer. Seriously, when it's going to reduce so much of your weight, your sleep apnea is going to go away. And sleep hygiene, extremely, very important. We all know about lifestyle modifications. Treatment comparison, most effective CPAP, next oral appliance. You need to do the lifestyle no matter what. The tirzepatide, Zepbound for sleep, for decreasing your weight. The Inspire therapy. And its treatment is always individualized based on your severity and, some things where you have to see your doctor urgently when you stop breathing, when your partner says you're stopping breathing for more than 15 seconds, very dangerous. You're waking up with gasping and you can't breathe. People come in saying, I can't breathe, I'm dying in the night. We know immediately they have sleep apnea. And you can't drive during the day, it impairs you so much. And chest pains, a lot of chest pains, because remember, it causes the heart attacks. A lot of chest pains that you have at night or during the day or palpitations is related to sleep apnea. Please see your doctors for that. Atrial fibrillation. Huge risk for this. Federal regulations regarding pilots and commercial pilots, they have to be checked, treated before they can, be deemed safe to fly. Putting it all together, please tonight take your stop bank quiz. If it's more than 4, talk to your doctor. And then say, I want to be evaluated for sleep apnea. Take a home sleep test if your score is more. You should get that pretty soon. If diagnosed, then give it the right treatment. After that, please tell your family, because this could save somebody else. And I think that's about what I have. Resources, I'm going to leave that for the South Asian Heart Center to give up something for all of you to get into this. I'm sorry I went over a little bit. And
Thank you, Dr. Chirala, for the wonderful talk. And I think you've convinced some people that they need to use their CPAP machine.